So infection, this is module 4. Let's make it sweet and to the point. So let's say you're in the clinic and you're providing an urgent care appointment, and Morris Pierce is an 82-year-old man, and he's coming in and he's got some fatigue and malaise. Now there's a complicated workup, isn't it? There's lots of different things in an 82-year-old that can cause fatigue and malaise. But you're already generating some ideas and you're thinking, well, what systems does he have that could be causing these problems? So fatigue, you always think thyroid. Malaise, you always think could be endocrine, could be cardiovascular, could be respiratory. But the most common thing that you're going to see if someone has a relatively sudden onset of issues includes infection. So you have to break down whenever you have anybody with these kinds of issues. You have to be thinking about, well, what kinds of things can cause those issues? So let's start with some history. He's felt lousy for the past day or so. He's thinking he had a fever last night, had some shaking chills, and he doesn't have much of an appetite. Well, we're headed in a much more infectious direction, aren't we? Fever, however, can be associated with infections, but it also can be associated with cancers or neurologic disorders. So we have to be thinking about those as well. Think about whether or not he has any other physical exam findings that would make us think that he has either of these. And we're going to look for those things. We're also going to go back and we're going to look at his past medical history. So we used to call it Parkinson's disease. More technically, it's now Parkinson's disease. He's also a type 2 diabetic. Type 2 diabetics, of course, have greater risk of sugar problems, but they also have greater risk of infection as well, don't they? So you're kind of moving things up and down on the list depending on the information. You're still kind of thinking infection or inflammation. So family history in an 82-year-old probably isn't going to be that important, is it? It's going to be something that might be important as far as like, oh, I'm worried because my father died of this. On the other hand, most 82-year-olds have a lot more environmental factors that are going to be there rather than genetic. So if a genetic issue has come up, it's going to have raised its head long before the person is 82. Lives with his wife. He's a retired accountant. He is currently a non-smoker, but he does have a 25-pack year history. He quit over 15 years ago, though. He's on metformin, 500 milligrams twice a day, as many type 2 diabetics would be. And when we ask him, we do his review of systems. We go through all his different systems, and we say, you know, do you have any issues with your extremities? Do you have any problems with your skin? He tells us, I've had a sore on my foot. I've had it for about 2 weeks. I've been walking on it, but it's still pretty achy. It gets better at night, but it still does hurt. We check his vital signs. Well, we look at his vital signs, and we see that his pulse is 98. Well, normal, but high normal. Temperature is 99.4, so that is a fever, but not really. Usually you have to be 100.4 or so to technically be a fever. We do know, however, that elderly people do often present atypically and may have an infection without a fever. His blood pressure is on the low side. He's really on not very many medicines for someone his age. And 96/48 is a relatively low blood pressure. So he's got a relatively low blood pressure. He's got a relatively high pulse. We're concerned. Postural vital signs will tell you whether or not this is related to dehydration or inadequate blood flow. Dehydration or low blood pressure that is related to fluid balance. Those page numbers are actually meaningless, so ignore them. So further on physical exam, his lungs are clear. He's got a regular rate and rhythm without murmurs, rubs, or gallops. His abdomen is soft, non-tender. He's got no hepatosplenomegaly, so no enlarged spleen or liver. We do see, though, on his right leg, a 10 centimeter. So that's a good big area. That's, 4 inches across of redness, warmth, and swelling. So he may have an infection in the subcutaneous tissue. So we sometimes, in the vernacular, call that cellulite. That subcutaneous tissue, if you've got an infection, we also refer to it as cellulitis. The two most common organisms that are going to cause cellulitis are both gram-positive organisms, staph and strep. In diabetics, however, we're going to see more enterobacteria and rarely some Clostridia. And we know that Clostridia is really hard to culture out. We know that it can really be a difficult infection to treat. And so you've got four different major types of Clostridia, three of which are specific diseases, one of which can be a skin infection. Tetany is what causes tetanus. C. diff is a normal flora in the bowel of about 40% of the population. If you kill all the other bacteria in the gut, those will overgrow. They'll cause an inflammation of the inside of the colon, so they cause it colitis. That colitis actually has enormous amounts of mucus to the point where it will actually coat the inside of the colon, and therefore we call that pseudomembranous colitis. Clostridium botulinum is botulism, and Clostridium perfringens can be a skin flora. So all infectious agents are recognized as antigens, and therefore, if you go back to your immunology, you know that we're possibly going to activate T cells or B cells. The T cells are going to be best at recognizing the things that HIV patients get, like funguses or viral infections. Less common that they'll be helpful in bacterial infections, but we need to mount a defense, right? So this defense is an inflammatory reaction, and there's really two major components, a vascular reaction and a cellular reaction. In the vascular reaction, what happens is you secrete cytokines, you secrete histamine, you have a momentary constriction, but then a rapid vasodilatation, and that's what histamine does. And that's why when you have lots of problems with histamine in your nose, all of your nose swells up and becomes congested. And that's why we do antihistamines for nasal issues. There's basically, the old-fashioned way of thinking of this was rubor, calor, and tumor. Tumor actually in that sense just means edema. Calor means temperature. Rubor means redness. So it becomes red, warm, and swollen. You basically try to dilute the offender by increasing your capillary permeability, and that increases your edema. You may get some pain, which is dolor, and if you have loss of function, you've got all five of the major elements that define inflammation. So what white cells would you expect to move into the area? Well, granulocytes are white blood cells that have granules in them. There's three major types of granulocytes. One that stains neutral, and those are called neutrophils. One which stains basic, and those are called basophils. And one which stains acidic, and those are actually called eosinophils, because eos is Greek for dawn, and often the dawn is red, and that's the color for acidity, but you just have to memorize that too. Neutrophils also can be called other things. Neutrophils are also called polys, or polymorphonuclear leukocytes, PMNs, and they're also called segmented neutrophils or bands. And so the neutrophils usually start out as a sort of a single cell with one band around it. Then they extend to two bands around it, and then they extend to three bands around it, and then they look like they're segmented after they're more fully mature. Therefore, the ones that are shorter and smaller are the more immature ones. And so very frequently in the old days, we used to call that a band count or bandemia. Frequently now, we actually refer to those as just immature granulocytes or an IG count. So the neutrophils get there within 90 minutes of the injury. Lots of other substances have also been marshaled. Mostly these are the cytokines, those substances that are there to call out white cells and mast cells and all those other things. I apologize for the incorrect abbreviation for etc. So if the invader is a non-bacterial antigen, something like a bee sting, then the allergic response, something like the eosinophils, would be the primary response. And they have IgE on them. And therefore, anything that blocks IgE also blocks eosinophils. And this is the basis of some of the new anti-asthma medicines. But you can get a pretty substantial response. The big thing with a bee sting is that you've got huge amounts of histamine that are responded to in some patients. And with that extremely large amount of histamine, you end up getting a response called anaphylaxis, in which there is huge blood flow to the periphery, and then you lose blood flow to the brain and heart and vital organs. Now, the basophils often get there a little bit sooner because they're actually in the tissues. They're essentially the same. A physiologist would argue with me that they are subtly different from mast cells, but they're basically the same as mast cells. And this is the reason they don't show up in the blood count in significant numbers, is that they are out in the periphery. If they do show up in the blood count in significant numbers, it is sort of a concerning sign because many cancers will do that. Myeloproliferative disorder just means a cancer of the bone marrow in which you're making too many of certain types of cells. So let's look at his white blood count and differential. So his white blood count is 14,200, with the normal being 4,500 to 10,800. So it's elevated. He's got 75% segs, 6% bands, lymphs are low, monos are low, eos are low, and basos are low. Now, the thing that you have to remember about the differential is that this always adds up to 100%. So that if you happen to have somebody that totally lacked lymphocytes, they would actually have a very low lymphocyte count, but they would have a disproportionate amount of segs and bands because they didn't have those lymphocytes. So it is very useful to look at the absolute counts as well, and probably essential at this point. Why didn't his lymphocyte count go up? Well, the norm is 25 to 45. His is 15%. In fact, his probably is normal when we figure out the normal percentages. And so therefore, it's really only because the segs and bands are up and they're taking up so much of the percentage that the lymphs look like they're low. So if we basically take the percent of lymphs, we multiply it times the total white blood count, we'll get that absolute lymphocyte count. 15% of 14,200, we know the normal range for lymphs is actually 1,700 to 3,500. His count is 2,130. Therefore, his absolute lymphocyte count is actually normal. Well, what else happens? There's a bunch of other substances that are released in the cells in response to this invasion by antigens, and several of these include histamine, and we've already talked about what that does. What drugs block it? Antihistamines. There's actually two generations of antihistamines. The non-specific ones block both histamine 1 and histamine 2. This is something like Benadryl. Histamine 1 is the allergy one. Histamine 2 pretty much only occurs in the stomach, although about 5% of the histamine in the skin is histamine 2. The newer so-called non-sedating antihistamines or second-generation antihistamines, such as Claritin or Allegra. Zyrtec is technically not non-sedating because it actually is 1 percentage point off what you'd expect with placebo, but it really is a second generation, and it's a long-acting, and it's a very effective one. They have better histamine 1 blocking than they do histamine 2, and therefore sometimes we'll actually put people on a histamine blocker and a histamine 2 blocker. Histamine 2 blockers would be things like Pepcid, Tagamet, those kinds of things. We'll talk about those more when we get to stomach issues. Prostaglandins are also cytokines. They basically attract white blood cells and other immune cells to the area. We know that originally we found them in the prostate gland, but we now know they occur everywhere in the body. I wish they'd change the name to something else because it is very confusing. But once they name something, boy, they seem to really leave it there. Mononucleosis has nothing to do with monocytes, but boy, we still call it that because they thought it did when it first came out. And then thromboxane is also one of the cytokines that are important. That's a mediator of prostaglandins and can affect blood clotting. We'll talk about that more when we get to blood clotting. So leukotrienes are another cytokine. If you look at the Flonase box, it says there's 6 kinds: histamine, leukotrienes, interleukins. It's actually very interesting. They block the LOX inhibitors. The COX inhibitors are what the prostaglandin blockers, such as Advil, which is ibuprofen or naproxen, or any of those NSAIDs are actually prostaglandin blockers. We used to call the leukotrienes the substance of slow-reacting anaphylaxis. We now know that it's better to refer to them as leukotrienes. Platelet activating factor, again, it's going to affect clotting, and when you have somebody that has infection, they are going to be a bit more likely to get clots, and this is one of the many reasons when we have somebody that has a severe infection and gets admitted to the hospital, especially if they're on bed rest, we give them something that's going to decrease their risk of developing a blood clot. So the acute phase response can be hours or days. The plasma proteins can change, your total protein and your albumin can change. The SED rate will go up. This is the erythrocyte sedimentation rate. So they basically take some blood, they stick it in the tube, and they watch how long it takes the erythrocytes to fall down and how many of them fall down. After an hour, they measure them. And the normal is probably 15 to 20 millimeters. If it's substantially more than that, we know that there's signs of inflammation in the body. The CRP is another way to measure that with C-reactive protein. It's actually a little bit quicker to get that test back than the SED rate. But they'll also develop leukocytes, which is the fancy name for white blood cells. People will develop fever, and they'll also develop more fibrinogen, again, putting them at a greater risk for clotting. Exudates, so the body starts oozing out all of these things that have these white cells in them. It has these immune cells in them. They can develop, a serous, which is a watery discharge, a purulent, which seems to have a lot of white cells and looks almost pussy. They can be fibrinous, and they can even ulcerate if it's severe. Why is Maury's blood pressure low? We do worry whenever anybody has an infection and it's low that they may have a gram-negative infection, because gram-negative infections, because of the toxins that gram-negative bacteria release, can cause a low blood pressure and can actually cause shock and can actually cause septicemia and can, in fact, die. The interleukins and the tumor necrosis factor are already causing this vasodilatation with infection. You add the effect of the gram-negative bacteria to that, you can really drop the blood pressure low. The other thing that's kind of interesting is that if you give bacteria an antibiotic dose, they'll often lyse, and sometimes the endotoxins will come out, which are even worse than the exotoxins. So definition of shock is inability to perfuse your essential organs. Usually it's diagnosed by low blood pressure and other signs, but really shock is the inability to perfuse your organs. And we also talked about shock in the case of anaphylactic shock. That person has a normal blood volume, but all of the blood is sequestered out in the periphery because of that vasodilatation. When you have the endotoxins released, you'll get this complement cascade. We talked about the complement. You'll get the coagulation cascade. You'll get these vasodilating prostaglandins. And so if you have this, sometimes we actually have to give a medicine that will cause the blood vessels to constrict. We call those pressors. Other times we can use anti-prostaglandin medicines like NSAIDs, and we're also going to make sure that we give them something that's going to stop them from getting a lethal blood clot. Again, ignore the page number. Sepsis is a severe problem. I will probably post a couple of other videos, including probably the Z-Dog video. I'm not sure you learn a lot from Z-Dog, but he's kind of fun to listen to, and I think you pick up a nugget here and there. High mortality rate from septic shock, and you basically get similar effects that you'd get from trauma or any other overwhelming inflammation. You can have a mild respiratory alkalosis because they're breathing a little faster and they're blowing off some carbon dioxide. DIC, which is disseminated intravascular coagulation, can occur in which you get blood clots in some places, and because all of the platelets are taken up there, they'll actually start to bleed in other places. This, of course, is not a good thing. Sympathetic nervous system stimulation, so you basically will give them a dopamine drip, you'll give them pressors, and that'll stimulate alpha, beta, and dopaminergic receptors. It is preferable to give them fluids and not have to give them pressors, but there are times that patients still do need pressors. Fever. Maury doesn't have a fever because he's elderly, and elderly people cannot always mount that amount of energy that it takes to increase the temperature, which does often make it harder for them to fight off infections. So the fever is usually caused by some kind of pyrogen, and usually in many cases it's a bacteria. For example, this one, often mediated by interleukin-1, and you'll get lots of other products of the inflammatory process as well. And just one last slide to try to tie immunity, infection, and cancers together. A number of the cancers are actually related to cells of the immune system. So when we get to the leukemias and multiple myeloma, that's acute lymphocytic leukemia, chronic lymphocytic leukemia, acute myelogenous leukemia, chronic myelogenous leukemia, and multiple myeloma. Multiple myeloma is a disorder of the plasma cells. Then all of these things do kind of tie together. So it gives you a basic quick and dirty. As I say, I think there's a bunch of other good commercial or other educational videos that are on YouTube that I'll post as well, but this should get us started.